Oh no. Whoa.
Okay, ready?
Oh, that's scary.
Number one, the first O, olfactory. Okay? Pretty much pure sensory, and it gives us our sense of smell. Okay? That's really all I need you to know about it. Okay? Number two, the optic, the second O. Okay? Pretty much sensory, gives us our sense of vision. Okay? Number three, a little more complicated, the oculomotor, right here. That's the third O. Okay?
Where is it?
And that gets all the muscles that you learned around the eye, except for the superior oblique and the lateral rectus. Okay? Because they are supplied by 4 and 6, the trochlear and the abducent nerve. Okay? The external, they're calling it the external, we know it as the lateral rectus muscle. Okay? That's the abducens, because what is it doing? It's abducting the eye. The lateral rectus abducts the eye laterally.
Okay.
Okay? So that's why they call it the abducent nerve. And the trochlear gets the superior oblique, so if I had a problem with that one, I'd have a problem looking down and out. Okay? Because that's what the superior oblique does for me. It helps with that. Okay? Remember, if I'm looking at you, my right superior oblique is coming from the nasal side. It's going up, wrapping around a little hook, okay, a little trochlea. That's how it gets the name, a little pulley. That's what it means. And then it's attaching to the back part of the eye from the side. So when it pulls my eye forward, it's pulling it down and out. Okay, so my vision down here is my superior oblique on either side, helping me to do that a lot. Okay, so, but if I had, let's say I have a third nerve, an oculomotor lesion, would I be able to look up and down very well?
No.
Probably not, okay? Because that gets the superior rectus and the inferior rectus, okay? So I'm going to have a palsy of vertical vision, of elevating the eye, okay? If I have an abducent nerve injury, let's say on the right, what am I going to have a problem doing?
Looking that way. Looking out.
Looking out with the
Looking
right
out,
eye.
yeah.
The lateral rectus is going to pull that eye out
Yep.
to the other side. So what's going to happen if you have a person with a 6 nerve injury, okay, or a congenital problem, you tell them to look out. They can't look out with the right eye, but they'll look over with the left because the medial rectus is still working.
Okay.
Okay, so their eyes will just cross. So that one eye will just go toward the nose, and the other one will stay straight because it can't look out. So you can predict what the problems will be.
Like a lazy eye, does that have anything to do with it?
It has issues with the nerve function and the muscles sometimes. And so, but they can get pretty complicated for different reasons. But you almost can predict what your eye can and can't do by just knowing which nerves supply the muscles you've already learned. Okay. So we'll leave that for now. Notice we've skipped one. We've got 3, 4, and 6. 5 is a very important one right here. It has a big ganglia. That is the trigeminal nerve. Okay, right here. That is sensory to the face. Okay? And it has, as well as motor to the muscles of mastication. Okay, right here. So it gets the temporalis, the masseter, and the pterygoids. So all your chewing is due to trigeminal nerve, okay? And the sensory to your face, it's kind of interesting why it doesn't get the facial muscles, but it doesn't. It's only sensory to the face, and everything in the sinuses and the teeth, and I mean everything in the face it's sensory to, okay? So you're getting a tooth pulled, it's a trigeminal nerve that's going to show you the pain. And you get punched in the eye, it's a trigeminal nerve that's going to be the pain fibers. It has 3 branches, which is why they show it in different colors here. First, second, and third branch, they have names, the ophthalmic, the maxillary, and the mandibular branch. They're coming out of little holes in the brain that you already know. The superior orbital fissure, the Rolando,
The
Valley, that's where these 3 branches come out. Okay? So, clinically, it's interesting to know the arrangement there, because Things like herpes, sores, they live in the nerve ganglia of the trigeminal nerve. The virus lives there. And so when it wants to get active, it's going to come down one of those branches. Okay? You can actually get herpes-like blisters on anywhere on the face. It's more common around the mouth, but that's the mandibular branch. Okay? But you can get them above. If you get them above, that's probably maxillary branch. Okay? But you've all heard of shingles? Okay? That comes from another herpes-type virus, the herpes zoster virus. It's chickenpox is what it is. That lives in the ganglia too, as well as in all the ganglia along your spine.
Okay.
So when it gets active, it's going to give you the same kind of blisters. And it might come out of a spinal nerve and give you blisters in a row along the nerve, okay, or down the leg as the nerves go, the dermatomes go. But if it's in the trigeminal, you can get zoster blisters on your chin, your cheek, or your face, or all three. Okay, and I've seen some bad cases where people were just blistered up the whole side of their face with shingles. Okay? So, but that's the clinical relevance of that particular nerve there. It also, it's not shown you here, we'll talk about it when we get to the ear, but it also innervates a little tiny muscle in your ear that tenses up and holds your eardrum when you hear loud noises. Okay? It protects your eardrum. The facial nerve does the same thing with a little different muscle in the ear. Okay? If you were going to have problems with that, noises would just seem a little too loud. Okay? But it also tenses up when you're eating, so that eating potato chips doesn't drive you crazy. Okay? It tenses your eardrum up so you don't hear it as much. Okay? And that may be why that's hooked to the trigeminal, because it's working all the muscles of mastication. It knows when it's working. Okay? So.
Is that why some people who smack don't realize that they smack when they eat?
They think that
Well, I mean,
everybody can hear it
getting-
Possibly,
anyway.
right?
Well, I guess, yeah, we're getting a little esoteric there, though. I'm not sure I can
I
give you
think
an
they just
academic
think
answer to
everybody
the
can,
question.
everybody can hear it anyway with their mouth closed or open because they can hear it.
Sometimes they just like it. Okay, so we've gotten to 5, we've already done 6. 7, that's the facial nerve. Okay, it gets all the muscles of facial expression that we've already learned. Okay, so it also gets some of the salivary glands, and it gets the anterior 2/3 of the tongue for taste, not sensation. Okay, pain is still trigeminal, but taste is the facial nerve. Okay, the anterior 2/3 of the tongue. So, clinically, what you're going to see with this nerve is Bell's palsy. Anybody here ever had it? 'Cause it's
My
fairly
daughter
common.
did. My daughter had.
Yeah, it's fairly common. There's always somebody in class who's have been exposed to it. I don't know if I told you the story about some of the cases I saw, but I saw a lot of truck drivers who got it because they're driving with the window open, the cold air just irritates that facial nerve, and all of a sudden they wake up the next morning and their face is droopy like this.
Yeah, she looked like something was bad wrong.
Yeah, it looked like they had a stroke. That's why they come in. Sometimes this is the first time you've ever seen a doctor, but that'll get you in. When your face is droopy, they tend to come in. Nothing, don't worry about it, don't worry. Don't make a fuss, don't make a fuss. Yeah. No, that's called Bell's palsy. It's not numb. Okay. Usually they'll come in saying, my face is numb, but it's not. The sensation is fine, that's trigeminal. But the motor weakness is from the facial nerve, and that's a Bell's palsy. And because it gets taste, sometimes they'll complain of problems about that. Because it also gets that little muscle in the ear that does the same thing that the trigeminal does, they'll also complain that noises are too loud. Okay? They can't close their eye completely because the orbicularis oculi is paralyzed. Okay? So you got to put a piece of tape over them when they sleep so their eye don't dry out. Okay? Usually lasts a few weeks to a couple months, and sometimes you give them steroids and things like that to help to calm down the inflammation. Sometimes, pardon? Well, it's not completely. That's right. That's right. But you can hope within about 6 weeks you see a big improvement. But this can be caused, like I said, by any kind of irritation of the facial nerve like that. Getting punched, an ear infection. Okay, that facial nerve goes in the internal acoustic meatus, goes right by the inner ear or the middle ear. So any infection in there can cause swelling to the nerve, and that's where you get the hearing problem because it's deep. That's deep, okay? Out here, you probably wouldn't have a problem with the hearing, okay? But that's Bell's palsy, okay? Seventh nerve.
So that's why you can't hear when you have an ear infection.
No,
Okay.
no, that's because you got
Misunderstood that.
fluid in the middle ear
Okay.
usually, okay? And the eardrum can't vibrate, so you can't hear.
Okay.
Okay, it just fills up with mucus and fluid, okay? So that's a little different issue.
Okay.
That's 7. 8 is
That
the,
doesn't start with the name.
some people call it the auditory nerve.
Oh,
Yeah, auditory, and or acoustic, the acoustic nerve. So vestibular cochlear, that's 8. Hearing and balance, the vestibular apparatus here. We're going to learn how these work when we talk about the ear. This is the cochlea, just like conch, it means shell, the coiled shell. And so it's pretty much all sensory. And you can imagine what kind of problems you'll have when you can't hold your balance or when you can't hear. Okay, so we'll pass that one up for a second here. 9, glossopharyngeal. Anytime you see glosso, we're talking about tongue. Okay, glossitis is an inflammation of the tongue. Okay? So and pharynx is the throat. Okay, so glossopharyngeal nerve. This is motor for your swallowing muscles in your throat. Okay, and it's also sensory for that same part of your throat. Okay, and this also gets the back part of the tongue for taste. Okay? We call it the back 9, sort of a golfing analog. The back 9 is 9, glossopharyngeal, number 9. Okay, so then 10, vagus, does all sorts of things. This is the one that really gets out of the head region, okay, and heads on down. It's going to control heart rate. It's part of the parasympathetic system, which is the rest and digest system. So it's going to slow down the heart, but it'll speed up the stomach contractions, speed up intestinal contractions. It has some controlling factors on blood flow through the organs, the liver, the spleen, that sort of thing, and just all sorts of things like that. Okay, and it's going to have sensory fibers as well coming back up through it, okay, that are going to give you a sense of gas pain, things like that. When your intestines are stretched, okay, then that's how you're going to know it's uncomfortable because of the vagus nerve, the internal sensation. Now, your body isn't very good at looking at those sorts of pains. You know how when you have a stomach ache, it just kind of all aches. Your brain can't localize the pain very well. So I even with my eyes closed, I know where this is coming from,
Right.
very specifically. But if I did that along one of my intestines, my brain wouldn't be able to know where it was. It would just feel achy. Okay. Same way with heart. You just feel this pressure in your chest, but it doesn't feel like the lower part of my heart is hurting. It's just a vague sensation of pain or pressure. And the brain can even cross up some of the wires and fibers, and that's why you get referred pain. So, like some people, when they have a heart attack, their left arm hurts, okay? Because your brain just isn't very good at telling where that came from, okay? Same way with other things. Males, you get testicle injuries, you get referred pain into the abdomen. It feels like you're having an appendicitis attack, okay? And vice versa. Appendicitis usually is very vaguely just uncomfortable until it starts to irritate the peritoneum, and then it localizes to the right lower quadrant. Okay, just so those are what we mean by referred pain. Gallbladder pain localizes just underneath the scapula on the right.
Yeah.
So people who are having gallbladder attacks will complain about the back pain as well.
So that one vagus nerve, as it comes out, it actually is branching off to all these different areas.
There's lots of different little branches. And the interesting thing is, though, you can cut it and you won't miss it too much.
Really?
Okay? Because your GI tract will still work. Okay, you can still swallow. Your stomach will still contract because of the enteric nervous
That's
system.
it, done.
Okay, that the ancient worm gut
Yep.
nerves that control your GI tract. Your heart rate might speed up a little bit. Okay, your resting heart rate might go up a little bit if the vagus is not there to tone it down. Okay, but otherwise you can do vagotomies, and they used to do that for ulcers. They used to think that all ulcers were caused by too much acid, so they would do vagotomy and cut the vagus nerve to the stomach, and decrease the stomach acid production, okay? Because after all, that's a rest and digest function, right? Okay, so now we know it's not. It's the H. pylori bacteria that causes it, okay? So we just treat them with antibiotics and Prilosec. So that's vagus, very important nerve. And we'll talk a little bit more about that when we talk about the parasympathetic and sympathetic system next week, okay? The last thing I've got here is 11, the accessory, or spinal accessory, that gets the sternocleidomastoid and the trapezius. Interesting that all of a sudden you're getting external muscles from cranial nerves, okay? That's kind of an odd man out there, okay? But, and then the hypoglossal, remember you learned that little hypoglossal canal right by the foramen magnum, okay? That's where it goes out and heads underneath your head up to your tongue. Under the tongue is basically literally what it means. This is all the muscles of the tongue. So if you have a hypoglossal injury, well, two hypoglossal injuries, you can't stick out your tongue, you can't move your tongue side to side. You can't lift your tongue up, you can't push it against your teeth to talk, okay? So you have issues with speech when you have a hypoglossal injury. If you only have one side out, like with a stroke or a brainstem stroke, the old mnemonic in medical school was that when you tell a patient to stick out their tongue, you have two good muscles, okay? But one of them's out now. The good one will push the tongue out and over. So we always say that the tongue points to the side with the lesion, okay? And that's how you determine which side has got the problem. Okay? The tongue will point to the bad side. Okay?
Would it affect your ability to chew?
I've got 3 minutes to do a neurological exam for you. Testing all the cranial nerves, okay? This is what you do in the doctor's office 5 times a day when people come in for full physicals, or if you're in a hospital and you've got some kind of neurological issue, whatever. You want to know if all the cranial nerves are working. It's malpractice not to check things, okay? Usually if it's just routine, you're not going to check their sense of smell. But if there's a question, we usually kept some coffee or peppermint around so that we could blind them, you know, and then wave it in front and say, what do you smell? That's an easy way of checking. The visual acuity, just the eye chart. You can see how well they can see. You can use the ophthalmoscope to see if there's any problems with the cornea, the lens, or the retina, that sort of thing. And if it seems okay and they're not complaining of anything, that's usually as far as you go. 3, oculomotor. I just go up. I can test 4, 6, 3, 4, and 6 just by saying this. Follow my finger for me.
Oh, yeah.
Okay. You make a big H. Okay. Going across, and then down over here, down and out, superior oblique, and up. Okay, good. All his extraocular muscles are intact. Then you check field of vision. Which one of my hands is moving? Okay? It looks like he's got a normal field of vision. And you can do it this way too, okay? Because you want to check for field defects, because you will see in a little bit that the optic radiations going back to the occipital lobe can be hacked off in different areas by strokes. And you're going to lose pieces of a pie, you know. We call it pie in the sky or pie on the floor, you know. So you want to check the visual fields in all ways if you think they have a neurological problem. How do we do? Now we do 5. It's just sensory to the face. If you're worried about it and you want to test it well, you can just touch them, or you get a little thread of a Q-tip and something. You just touch them real finely and see if they can feel that. Okay, that's trigeminal. And you want to feel all 3 branches. Okay. Then tell them to bite down. Can you bite down hard for me? Okay. Can you move your jaw side to side? You tested all the muscles of mastication. Okay, that's 5. 7. Muscles of facial expression. That's the stupid stuff when everybody who's watching thinks the doctor's crazy because he's going, smile for me, smile for me. Okay? That's what he's doing. He's testing all the facial expression muscles. He's saying, squint your eyes tight for me. Can you raise your eyebrows way up like this? Okay? Can you put your lips up like this? Good. Okay. And that's what he's testing, is all those muscles of facial expression. And then, let's see, taste. If somebody's complaining they don't have problems with taste, you can always, you know, check that with a piece of sugar or salt or whatever. That's not something we usually do typically, though. Then 8, hearing. The simplest thing is just to say, almost everybody with normal hearing can hear at arm's length. They can hear fingers moving. Okay, you can probably hear it from there. Okay, but if they can't, you need to be a little iffy. And then you look in the ear too to check, make sure there's no blockages, make sure that the eardrum looks okay. 9, glossopharyngeal. How do you think you might test that?
Just swallow.
Well, yeah, you can put your hand on their throat and say, swallow for me. You should feel things moving in there. Okay, that's motor. And if it's a routine physical, they're not usually complaining of swallowing problems, okay? But they may have it in the hospital, okay? And then you how do you test the sensory?
The stick.
Tongue depressor.
Tongue depressor.
See if they've got a gag reflex.
Okay.
So you did that on purpose?
I've
I've always wondered.
Me
You're
too.
testing the gag reflex, that's not
What if you don't
okay.
gag?
The sensory is trigeminal. You don't want to just put it on the tongue.
No, I'm serious.
Okay.
That's all right.
What if, when they do that, what if you don't gag?
Well, that's an issue with the sensation back there. Yeah, and especially hospitalized patients, it's a problem because they're gonna be choking on things they eat. A gag reflex protects you from swallowing and aspirating your food. Okay? So, I mean, mine is sometimes, it varies, but sometimes it's real sensitive. I mean, they can't even take x-rays of my teeth because I'm like, put those things in there, so I can gag myself just brushing my teeth. Here we go, 9. All right, so yeah, they gag you on purpose. Because if they're just touching the tongue, that's just sensation, and that is trigeminal.
Okay.
Okay, they got to gag you to check 9. Vagus, you're not really doing too many tests. Your heart rate and things like that will show that that's normal. Blood pressure, whatever is vagus is mostly internal, so you're not testing that routinely. Accessory, easy. Just shrug your shoulders, turn your head. Okay, that's sternobottomastoid,
Stick
trapezius.
out your tongue.
Hypoglossal, stick out your tongue. Side to side. You got to test it all 12. Okay. Bye. Sorry.
What is the SSMMB?